Afternoon. Good afternoon. Hope you all had a nice lunch break. My name is Ishani Mather. I am from Management Sciences for Health out of Arlington, Virginia. I'm very excited to welcome you all to our afternoon side session titled Institutionalizing HTA in Africa. What could we learn from real-life examples in low and middle-income countries? Huge thanks to MSH and KEMRI for organizing this program. And I just wanted to give you a quick run of show and talk about a couple logistics before we get into the content of the session. So we'll start with opening remarks from Dr. Justice Nonvignon, which will be followed by presentations from KEMRI and MSH. Before we turn it over to colleagues from Ghana, Malawi, and Rwanda to share their experiences with HTA. We'll have a Q&A, and then a plenary discussion led by MSH and KEMRI. The session should conclude around 4, which gives us all plenty of time to get ready before the opening session at 5 p.m. Just a quick note that if you need translation, you can find it using the AfHEA app for the session. Just go to the session little page, and there's a link for translation, and you will have to use your own headphones. But I'll be doing my best to keep us on time and keep us running. So looking forward to a really engaging session. But for now, I will turn it over to Dr. Justice to kick us off with some opening remarks.
Thank you. Thank you, Shani. Good afternoon. Good afternoon. Okay. Thanks so much for spending your afternoon with us. My name is Justice Nonvignon, and I make these remarks on behalf of Management Sciences for Health, but also KEMRI, Wellcome Trust. This session is jointly organized by these two organizations who have, each been very, very strong in the space of health technology assessments. As you would hear from Marion, MSH has done quite a lot in helping to institutionalize HTA in Ukraine and in other parts of the world, and has recently been tapping into some of that experience for Africa. Whereas KEMRI Wellcome Trust, hosts the African HTA network. So for those of you who don't know, the Afro HTA, you would hear more from Angela about that. Afro HTA is African HTA network. It's more or less the equivalent of HTA International for Africa. And this network was set up by Africa CDC and KEMRI and a couple of other partners under the broader partnership of the International Decision Support Initiative, hosted by KEMRI, and it has membership from across institutions in Africa. What it seeks to do is to strengthen the supply base for HTA, while also working with ministries of health under the leadership of Africa CDC to strengthen the demand by ministries for HTA. And there are a couple of steps to that. One of those steps was Africa CDC's development and launch of a continental framework for evidence-informed priority setting. And of course, the next steps would be other activities. I'm sure you're going to discuss those. Okay. And so the purpose of this discussion really is to have a conversation. We know that, well, what better time to talk about priority setting, given all that's happening. We know that financing does not necessarily mean always more money, especially in our context. It means being efficient with what you have. And with the demand we've seen from ministries in many countries across the years, it's important for us to tap into these lessons. And so while you see 3 countries present their specific lessons, the idea is not to simply hear from the 3 countries and have a Q&A. The idea is to hear from what's happening in your countries, what's the state of HTA institutionalization in your countries, and how can these organizations work to support, what you are doing, or what's the current state and what's the future? What are the next steps for ensuring that our countries actually institutionalize priority setting and not use them as ad hoc tools? So I'm happy and honored to provide these remarks on behalf of my colleague, Edwin Barasa, who is the acting director of Kemri Wellcome Trust, but who also for many years had been working alongside Africa CDC and other stakeholders in this whole space of HTA institutionalization. So with those, I would like to leave it to the people who would make the presentations and lead the discussions. And hopefully we have a very engaging session, and we together co-create what the next steps of HTA institutionalization will be in Africa. Thank you.
Thank you, Justice. So we'll go ahead and get started with our presentations. Please welcome Dr. Angela Kairu to discuss AfroHTA Network.
So as the slides are going up, as you have heard, I'm Dr. Angela Cairo from Kemri Wellcome Trust, the Health Economics Research Unit, and we have been working within the HTA space for a couple of years. And today I just want to present an initiative that we are hoping to get as many of your countries involved in to enable us to push the HTA agenda forward. So I'll also present on behalf of Professor Edwin Baraza as well. Next slide, please. Yeah, so as Justice has mentioned, and as we all know, UHC is currently being prioritized in all the countries. And in addition to that, we also have the donor transition that is currently happening. And because of that, now we need to find efficient ways and evidence-informed ways of informing decision-making when it comes to resource allocation. So HTA is gaining attention as one of the ways or avenues to inform strategic purchasing, but also to inform decisions when it comes to efficiency of health systems in Africa. Currently, we have a number of African countries which have begun their process or path in establishing HTA systems in their countries. So for instance, we have countries like Ghana, Egypt, Kenya, Malawi, Tanzania, Ethiopia, Rwanda, South Africa, Uganda. There are probably a couple I've not mentioned here, but I think when we do have the discussion session, we'll get to hear more about that. And definitely would love to have you to be a part of the network as well. So next slide. So as these countries are establishing their HTA systems, there are a number of challenges that have been found. So some of them include the lack of awareness of what HTA is, especially amongst policymakers. So it might be common knowledge within the research field, but when you go to the Ministry of Health or all these international organizations, they don't know what you're talking about when you speak about HTA. So there's that lack of awareness or low awareness. There's also limited capacity and skills for HTA implementation. And HTA is multidisciplinary. So you have your health economists, the people who do evidence synthesis, epidemiologists, and I think there's a bit of talk towards capacity building within Africa when it comes to health economics. So this also affects HTA implementation. We also have disjointed efforts in research. So where you find that countries are doing probably the same topic of research, but there's not a lot of collaboration, and this collaboration tends to promote, you're able to leverage, capacities when it comes to financial or technical, where you have shortfalls. So everyone is sort of doing their own thing, whereas collaboration would be more beneficial. And then there's also one of the biggest challenges, which is limited access to data and evidence to inform HT assessments. So you'll find that when countries are now going to establish their benefit packages, for instance, one of the biggest shortfalls is where to get this data from or the evidence. So there's usually a lot of struggle when that process is being undertaken. Next slide. Next slide, please. So speaking of those challenges, there are regions around the world that have HTA networks. So more commonly, you have areas like Asia, where there's the HTA Asia link network or conference, which they hold every year. In Europe, you have a couple of HTA networks as well. I think HTA, I can't remember all the names, in South America as well. And these networks have shown that the collaboration amongst countries in such regions is quite beneficial, and it supports the institutionalization process of HTA in countries. So how it does this is when countries come together, they're able to reduce duplication of efforts based on the different HTA work or projects that they are carrying out, and they're able to leverage on member resources. So just not the financial, but you have the technical capacity, advocacy of HTA as well. So this then tends to facilitate mobilization of the scarce resources that we are all speaking about. So it tends to be more beneficial to have these collaborations to support the reform processes. So part of what we are trying to do here, basically, as Africa. So having mentioned some of the few countries that have already started their journey, there's an initiative now that is looking to establish a collaborative platform for HTA, otherwise known as AfHEA network, which I'll speak to in the next few slides, to be able to push forward this agenda. Next slide, please. Next slide, please. Yeah. So as Justice had mentioned, this initiative has been collaborative work between KEMRI, Africa CDC, and IDSI, otherwise known as Information Decision Support Initiative, that does a lot of work around priority setting. And we were able to establish, or although it's in its infancy stages, a network of academic institutions, public national HTA agencies, research institutions, ministries of health, and regional and policy-making bodies. So basically, within these institutions, those that are concerned with HTA processes. So trying to bring them together to see how we can collaborate and leverage on the resources that we have. Next slide, please. Okay, I think the slides are a bit slow, but yeah. So I'll speak to just some of the network objectives that we have, although at the end of the presentation, there's a QR code and which you can scan to go to the website that has a lot more information. So we have 5 major network objectives. So one is to facilitate knowledge exchange and peer learning among members. So there are those initiatives going on as well within the health economic space, but we'd like to bring them towards HTA, develop capacity in the African region for skills that are required for HTA implementation, support advocacy and policy engagement for context of appropriate HTA in the African region, collaborate on the generation of health economics and policy research with a focus on HTA, and lastly, to facilitate collaborative development of global public goods. So on the website, once you search for it and go on, there are more details specific to these objectives in terms of how we aim to achieve them. But I'll give you the QR code at the end. So next slide, please. Yeah. So regarding membership, currently we have representatives from different institutions across Africa, and I'll show that in the next slide. And there is a provision for any institution here whether it's a research institution, Ministry of Health, department that would like to join the network on the website. There's a provision for that. But basically, we aim to have African country public HTA agencies, technical working groups, or committees within the membership, ministries of health, HTA departments, or units that work within the space, any academic research institutions, regional HTA agencies, for instance, the Africa CDC Health Economic Unit, WHO Afro, and any evidence synthesis centers in Africa, such as Cochrane. So that's our aim in terms of the membership that we are looking to grow within the network. Next slide, please. Yes. So currently, these are the country representatives that we have within the network. So I won't go through the entire list, but around 13 countries, and we'll continue to update this as more people join, but this is the current status, in addition to the Africa CDC Health Economics Unit. So we look to grow this membership, and it doesn't have to, I know there are a lot of universities and research institutes listed there, but we look to grow beyond that as well. Yeah. Next slide, please. Okay. So I'll just quickly state some of the activities within the network. As I had mentioned, we're still in the very initial stages. We have started some activities, and I'll just mention here which ones, but some of the ones listed across the slides are more of the long term that we aim to achieve, but there are some short term ones that we've already started working on. So in terms of knowledge exchange and peer learning, so we aim to do a quarterly HTA Africa newsletter, have HTA webinars. I think in the past we've had maybe 2 of those, but this will be more frequent in this year. Also develop an open access repository of HTA assessments, policies, strategies, and methods, guidelines in Africa. And eventually, in the long term, be able to hold a biannual HTA Africa conference, sort of what the other networks in the other regions of the world do. Yeah, so that's more of a long-term goal. Next slide, please. Regarding capacity development, one of the activities is to develop and implement short courses on HTA in Africa, organize HTA skills building lessons in conferences such as this or AfHEA, implement a mentorship program that will link junior and senior health economics and policy experts with practical skills, and also be able to eventually support master's and PhD training in health economics across Africa. So of course, this will be a collaborative effort with other organizations that are looking to do this as well. Next slide, please. Regarding advocacy and policy engagement, is to be able to support regional in-country policy dialogues on HTA. So for instance, visiting or working with countries when they're having trainings or meetings regarding HTA. So being able to collaborate and engage ministries of health in that aspect. Also facilitating organized sessions on HTA. So for instance, this one, which is sort of introducing you to the network, but there shall be more in the conferences to come, health economic conferences to come. Facilitate knowledge exchange and study tours among African countries, and social media engagement on HTA in Africa to share HTA outputs. So as we continue to build the network. Next slide. Regarding developing of public goods, so we are working or planning or there. So I think under the tab of resources. So there are a couple of slides on the different aspects of HTA where one could be able to access this material and read through and have this. Also develop generic and adaptable process and methods guidelines for HTA. So this tends to be very context specific to each country, but eventually we'd be able to develop one that's adaptable across for those that don't have. Also work on a health-related quality of life measure for Africa. So regarding this, there's work that's already ongoing. So for instance, KEMRI is looking to develop this measure in Kenya, working with Nigeria and Zambia as well. And then Africa CDC is looking to work with Malawi, Cote d'Ivoire, and Rwanda. So we are hoping to at least get those 6 countries up and running. And I think South Africa is also planning to do a similar study. So just bringing those efforts together. And then the other thing is working with health economic schools in Africa to integrate HTA training as part of the curriculum. So this would be, collaborative with other organizations that are planning to do this. So in terms of the way forward, currently Health Economics Research Unit is a secretariat of the network. And when you go to the website, you'll be able to see the constitution for the AfroHTA in terms of some of the governance that we plan to establish within the network. Some of the resources that have been uploaded as well, such as the short curriculum, and a few documents that are building the resources of HTA within Kenya, within Africa, sorry. So the next steps that we are working towards in the course of this year is to establish governance organs or working groups amongst the members that we have, but also the ones that will join to lead implementation of the network affairs. So the various activities I've listed in the previous slides. And then just to let you know that membership of the network is free. When you go to the website, there's a tab there that says membership, and it has a provision for filling in your details, and that will be provided to the network email, and we'll be able to get back to you. Next slide, please. Which should be the QR code. So you can just take a picture of this or visit the website, and you'll be able to see a lot more information on the network. You can reach to the email there, which is afrohta@kemriwelcome.org. But you can also reach out to my email, which I can provide to you after the session. But there's a lot more information on the website. So thank you.
Thank you so much, Dr. Angela, for such a comprehensive initiation on the AfroHTA network. We'll have some time to ask questions in just a little bit, but I'm going to move us along to the next presentation, which is my colleague from MSH, Marian Marunji, who's going to talk about HTA institutionalization.
Thanks, Ishan. System level can be a tool or a process for priority setting, as long as that process is standardized, it's explicit, and it's considering the costs and benefits of whatever intervention technology that is being assessed. So again, the approach has to be systematic and would help countries make better decisions on how much money is spent for healthcare, minimizing wastage. This was talked about in yesterday's sessions, how countries are returning money back to the government. They are not effectively spending, and yet they say we don't have enough money to implement. So by institutionalizing HTA, you would have a standard process of kind of deciding how well to use the little that is available and achieve more health for what is available. Next slide, please. So HTA can be used to inform priority setting. As I've mentioned, it can be used to inform health benefit package design or formulation of essential medicines list. It can also be used for purchasing. Sorry, that second bullet should say purchasing. And in purchasing, We talk about things like pharmaceutical pricing or reimbursement for health insurance, drug selection, medical devices, out-of-pocket expenditures, and even costing. And HTA can also inform quality improvement. So, for example, standardizing practice, different interventions. A popular quote from a recent systematic review of HTA institutionalization in low and middle income countries that I like is, if countries are unable to spend more, they need to spend better. And that's the whole point of HTA. Next slide, please. So linking HTA to universal health coverage, as you'll notice, most of the countries in Africa that are advancing on HTA institutionalizations are those that have also made some form of advancement towards universal health coverage. Many of these countries have agendas to reach universal health coverage by a certain date or a certain year. And because of that, HTA has sort of gained traction in LMICs. Because previously, HTA was very well advanced in high-income countries, and that was not the case in low and middle-income countries. But now we see that because of the goal towards reaching universal health coverage, more and more countries are starting to institutionalize HTA. The goal of UHC is to provide effective health services to the population without financial hardship. And institutionalizing HTA helps us to contribute to this goal by improving resource allocation of those already finite resources. Next slide, please. So some of the challenges that are cross-cutting across most of the low and middle income countries regarding institutionalization of HTA include the fact that there is limited available budget for HTA, because HTA competes with a lot of other health priorities. So in the context of scarce resources, when someone doesn't fully understand how much benefit or return on investment HTA is going to provide, they would rather invest that money into something else. So the first one, definitely, as always, is limited funds. Then there's a lack of awareness, like Dr. Kairu pointed out. We haven't sensitized policymakers enough about HTA and its benefits and how much savings there would be if countries actually institutionalize HTA. Limited capacity, again, something that was talked about in the last presentation. Lack of explicit HTA policies and guidelines. Lack of local data. This is a very big problem. A lack of appropriate tools that are context specific. Then the fact that when there is no data that quantifies HTA in terms of net health gains and return on investment at country and systems level, then countries are, you don't have where to start to get buy-in if you don't have that kind of data. And where HTA is existent in low-income countries, activities are still uncoordinated and disconnected from policy. So, next slide, please. The whole process of institutionalization is to make something become a permanent or respected part of a society or organization. So HTA institutionalization is just about utilizing HTA as a normative practice to guide resource allocation decisions in the health system. Next slide. There are already a number of existing roadmaps for health technology assessment. The first one was designed by MSH, I think in 2020. The next one is a WHO roadmap, 2021. And then the last one is a IDSI toolkit. As you know, IDSI has been supporting many low and middle income countries with priority setting for health. Next slide, please. Today, I'll focus only on the MSH roadmap and how it was used to institutionalize HTA in Ukraine. Next slide. So basically what the key steps listed in the next slide, please, in the HTA roadmap that was designed by MSH is, first of all, agenda setting, identifying the window of opportunity for HTA, not making it a standalone thing, but making sure it is well incorporated into existing systems, because that's the only way you'll be able to sustain it. The next one is policy formulation, looking at good practices, identifying stakeholders, and making sure that each of these stakeholders understand their role. And then also clarifying the scope and purpose of HTA. As we talked about earlier, HTA can be used to inform so many things: health benefit package design, or designing the essential medicines list for universal health coverage, and a number of things. So you need to, first of all, design the scope. As you'll hear from the countries, they're using HTA for different things. So it's not always a one size fits all. Then on adoption, discussing the legal frameworks and making sure that it's set into a certain existing framework and policy guideline so that, again, it is sustainable. On implementation, the roadmap talks about different guidelines and methods and reference cases that can be used to actually set the stage for HTA in different countries. And then lastly, it has a part for impact evaluation, for checks and balances, constantly checking whether HTA is actually working. So we'll dive into the example for Ukraine. Next slide, please. And I'll try to be very quick. Next slide. So HTA institutionalization in Ukraine started in 2017 with support from SafeMed, which was an MSH supported project. And the minister, it just started off with the minister establishing a technical working group. So as you can see, there was no, we need guidelines, we need to put a body. It was just as simple as a technical working group. And it has later now, over the years, transitioned into an independent department. At that time, health spending in Ukraine was about 8.2% of the state budget, and high out-of-pocket expenditure, 47.9%. Then a roadmap was developed to provide strategic guidance, and then they used HTA to develop a national EML and streamline government procurement and distribution and prescribing. Next slide. So the next slide is a schematic of, over the years, like I said, it started in 2017. In 2019, the department was established at the State Expert Center. In 2020, that's, when the world was hit with COVID, but it continued. It was actually used during COVID, and that's when there was a second national HTA forum. In 2021, they developed the roadmap and expanded the EML for the first time and put up guidelines for HTA. In 2022, they updated the EML twice, met with stakeholders, and then that same year, HTA was fully legalized and integrated for decision-making by mid-2022. By 2023, there was a comprehensive capacity building program for HTA. The fourth National HTA Forum was conducted. And as you can see, between 2022 and 2023, and 2024, HTA was legalized as an independent agency in Ukraine. So right now in Ukraine, the process is that applications go in, whether from the MOH or manufacturers, and then the HTA department sits and provides initial expertise, conducts a rapid HTA. Once the report comes out, it is reviewed by the expert committee at the SEC, and then the Ministry of Health makes a decision whether or not to include this product in the EML, include it in the nomenclature, or start a managed entry agreement negotiation. Then the next step is that MOH makes the final decision on it, and then approval by the cabinet minister. So that's currently the process in Ukraine. They have a roadmap, again, mirrored to guidance from the MSH roadmap. I won't go through this in detail, but just the key point here is that countries need to contextualize their own steps or roadmap to take from the guidance offered by whether you use the MSH roadmap or the WHO roadmap and kind of customize it to what fits within that context. Next slide, please. Which I think is my last slide. And I just wanted to hint on the key takeaways as we wait to hear from the countries. First and foremost, political buy-in is important. And this starts with awareness, but awareness starts with data. Awareness has to have some evidence backing to it. Then an HTA body is not always a basic requirement to start HTA. As you could see from the example of Ukraine, it started just a simple technical working group and later transitioned into a body. The third takeaway is that countries can use a roadmap and then contextualize, but this document has to be a living document, constantly reiterating what works. And then partnerships, as Dr. Angela mentioned earlier, partnerships are important because they will help you leverage resources. We've seen this example, MSH's work with HTA Asia Link and many other countries in Southeast Asia. This partnership has helped the countries actually farm up their HTA work and HTA bodies. Then the other is building a network of practice. Luckily for Africa, we have AfroHTA, which has already set the foundation. So now it's about countries actually engaging. And then lastly, we don't need to spend more. We just need to spend better. Thank you.
Thank you so much, Marian. Don't go too far. I'd like to invite both of our presenters to maybe join me up here. And we have time to take a few questions if you have any. I'll ask you to just please be brief with your questions so that we can make time for the country presentations, but would love to hear from you all.
Thank you very much for very interesting presentations. I just had quite a quick one. Chai has worked quite closely with several governments on institutionalization of HTA processes and benefits package design, etc. And I think there's a risk sometimes of HTA becoming quite an academic exercise. And a lot of the academic exercises are extremely important as long as other things are in place too. So you can improve your quality of life measures, and you can institute the actual kind of HTA mechanics. But particularly in countries where there isn't output-based purchasing, I think it's great. You can feed into the EML, you can feed into a benefits package. But some of those prioritization decisions and making sure resource allocation decisions are actually based on what has been prioritized often don't exist. And so I think some of the low work in setting up those processes, I think is a crucial ingredient, and even determines whether it's time to do HTA or not, actually, yet. So I just love your opinions on, where some of the things you've talked about fit into that process and what other kind of contextual enablers need to be in place first. Also, just a very quick observation on the timeline in Ukraine, like its invasion was not mentioned. And so did that interfere with the institutionalization at all? That's a less important one.
Thank you so much. Maybe we'll take one more and then I'll turn it over to our speakers.
Thank you so much to our presenters, and thanks to the organizers. Mimi from Malawi. Okay, mine is not really a question but a comment, speaking from someone on the ground. So my plea is, I think, to MSH, to Camry. Yeah, we need your presence on the ground. I was privileged to attend a conference, I think 2 to 3 years ago, and that was the first time that I was faced with HTA. I'm a general economist, development economist. I'm not a health economist. I'm heading health financing. and I'm driving this in Malawi. But unfortunately, when I meet Minister of Justice to try to convince them so that they support us with the legal framework for HTA, I fail to explain to them what HTA is. It's a lot of work, it's a lot of effort. We are working with our colleagues from KUHES, the university, at least they can. But I remember the last time we met them, like a week or two ago, we're trying to come up with a legal framework. We have a draft Public Health Act. We think we can just bring, it's an opportune time for us to bring it there, but it took time for us to make them understand what HTA is. So apart from the regional workshops that we have attended personally, and I think Malawi would be happy to have some of you on the ground. Maybe you can come when we're having a workshop so that you're also able to also support so that people are able to understand. I like what you said is that people don't understand what HTA is. So we need to bring this now down on the ground. I'm happy that there is a network. I didn't know about it. Malawi will join, and I'm happy that it's for free. We like free things. Yeah, but I noted that it's only universities and research institutions. Is it that ministers of health are not aware of this? Are we not interested? But definitely we are interested, and we really want. And some of the things that came up in that meeting was that we need to do benchmarking. Where should we go? So we really want you as our big brothers to hold our hands so that we make progress in this important area. Thank you.
Just an additional question, probably, to Marion. I saw in one of your slides you're showing MOH as both being the applicant and on the other hand, the MOH being a decision maker. So I just wanted to get a sense of what's the balancing act like between the two, MOH on the other hand and MOH on the other side. Thank you.
Awesome. I think those are all great questions. I'm going to hand it over to one more question. Okay.
Merci beaucoup. Moi, je parle français. Hein. Je ne sais pas si l'interprète est prête. Donc, c'est une session qui nous intéresse beaucoup. Moi, je suis Madame Diao, Dr Chanegei. Je suis la coordonnatrice de la cellule d'économie de la santé au ministère de la Santé et de l'Action sociale. Nous sommes en train d'implémenter l'évaluation des technologies de la santé au ministère. Mais quand même, le nom évaluation des technologies ETS pose problème. Parce que des fois, quand on nous impute un dossier sur ce domaine-là, les autorités ont tendance à l'orienter vers ceux qui gèrent la digitalisation. Ils pensent que l'évaluation des technologies de la santé, c'est la digitalisation, alors que le contenu, c'est de l'évaluation économique de la santé. Donc, ce sont les économistes de la santé et ceux qui gèrent aussi la recherche qui doivent gérer ces questions-là. Nous sommes en train de voir comment l'institutionnaliser. Et nous avons déjà introduit une note qui met en place un comité technique. Parce que pour faire l'évaluation, il faut vraiment avoir une équipe pluridisciplinaire. Donc, chaque membre doit avoir une capacité sur un domaine bien précis. Si je donne l'exemple de la santé publique, il faut quelqu'un qui maîtrise la santé publique, un autre qui maîtrise l'économie de la santé, une autre personne qui maîtrise les statistiques, ainsi de suite, pour nous permettre vraiment d'avoir des résultats. Parce qu'au finish, cette évaluation des technologies de la santé permet d'améliorer la qualité des services, de réduire les coûts aussi qui sont liés à la santé et de promouvoir la technologie. Et ça, on ne peut pas le faire seul dans une direction ou bien dans une seule cellule d'économie de la santé. Il faut un comité. À part ce comité aussi, il faut une appropriation par les autorités. Il faut aussi les autorités et les partenaires techniques et financiers appuient le Sénégal pour qu'on puisse vraiment avancer vers cette évaluation des technologies de la santé. Nous avons une école, une institution qui forme des économistes de la santé. Dans le curriculum de formation, l'évaluation des technologies de la santé n'y figure pas. C'est le CESAC. Je pense que beaucoup de personnes qui sont là sont passés par le CESAC, les francophones, je ne dis pas les anglophones, mais les francophones, il y a beaucoup de francophones qui sont passés par cette institution pour faire la formation sur l'économie de la santé. Ce serait bien qu'à partir d'aujourd'hui, que ce domaine-là soit enseigné dans cette institution du CESAC. Vraiment, c'est une session, je suis avec des collègues, c'est une session qui nous intéresse beaucoup et nous voulons vraiment avoir un encadrement pour implémenter cette évaluation des technologies de la santé au Sénégal. Merci beaucoup.
Thank you so much for asking such thoughtful questions. I'm going to hand it over to our presenters to address in a couple of minutes, please.
Thank you. Thank you all for those questions. I'll take the first go, then I'll pass it on to Dr. Angela. So the first question from the gentleman from Chai, you asked what needs to be in place for some of these processes. I hope I got that right. Yeah, so like, you know, some of the questions that are popping up and both presentations mentioned, there's still a very big lack of awareness. And sometimes when you don't start with awareness, you're pretty much doing nothing. It's always going to sound technical. It's always going to sound academic. And a recent study that I found interesting from Uganda, they did perceptions of health workers and including the Ministry of Health about institutionalizing HTA. And the interesting outcome was that Ministry of Health actually felt like HTA benefits donors more than the government. So they still don't appreciate what many of our countries and policy people in power and people in authority to make policies and influence health reforms still don't understand what HTA is, because it has been made severely academic. And yes, most of the people involved, like you could see from the list of those involved at AfHEA, are academic institutions. So in my opinion, I believe we still have a lot more to do when it comes to awareness. That's one. Two, we still have to build capacity for implementers, because sometimes you go to these countries and it's the academic institutions supporting the ministries to, you know, start HTA or even have conversations about HTA. The expertise does not exist within our ministries. So building capacity is another, you know, great place to start before we bring in all these nice to have technical initiatives. And then someone asked about you still asked about Ukraine, the timeline. Yes. Interesting enough, the HTA body and the process was resilient when it started. But of course, at some point, most of MSH and most of the staff had to be evacuated to Turkey and other countries. So I'm definitely sure that has caused a halt in many services, not just HTA. But at the beginning of the invasion, HTA and SafeMed were still active within Ukraine. Then the question about the MOH being an applicant and an appraiser at the same time. Yes, departments within MOH can apply. For example, pharmacy department can still apply to have whatever technology they want included in the EML. But within the Ministry of Health, there is an HTA expert committee that makes decisions, appraisal decisions. So it's not that the same person who applies is the same person who appraises or approves these decisions. There was then a special expert committee, but it has now evolved into a separate body, an HTA body. Yeah. I think Justice will provide translation for but first.
So just to build up on what Marian has said in terms of the context-specific factors that need to be noted during the slope process. So largely with awareness and capacity building. So maybe I can give a country example for Kenya based on how our journey has been, although it's been very slow. But what we did in the initial stages was some very basic trainings on HTA concepts. So we had partnered with Thailand, HITAP, and we made sure that in these trainings, we invited not just, I think, in fact, most of our participants were either from the Ministry of Health or county level officials in the decision-making places to get them to understand what HTA is. So very basic concepts, nothing technical at all. We had maybe 2 or 3 trainings, but we also had a different level now that was a bit more technical for the users, for the doers, rather. So, I mean, that was a while back, but it has sort of built on to our journey to the point where we are now. We still do not have an established unit or department, but for instance, in the health reforms that we have that are currently going on, like the social health insurance, which have been enacted in law, there are bits of the HTA process that have been included in that law. So that means that in a way, HTA will still be conducted in the country, even though we still don't have the process as it should be. So the building of awareness, I think it might seem like a very small thing to do, but it's quite influential. And then in terms of having the presence of KEMRI and MSH on the ground, so yeah, that's one of the main objectives of the network, and we also want to hear from you is how we can support the different African countries to move forward. We have been able to work with a few countries as KEMRI. So for instance, Uganda and Zambia, where we're able to engage with them in some meetings that we went. So we met some people working in the ministry to sort of, again, introduce the HTA concepts. So we are still limited by the capacity that we have. So you can imagine how many African countries we have. If MSH and KEMRI is to go around, I think it would be quite overwhelming. But that's why we would like to have additional members into the network who can support this initiative as well. So the list that was here was mainly universities and research, but that's not by design. It's just by the contacts that we have at the moment. We've been reaching out to these contacts to connect us with their ministries now in the different countries, because they would know best who to involve. So that's an ongoing process. And as the months go by, this list will definitely reflect, you know, the ministries of health, any other agencies. But we would encourage, for you to reach out with that information, and we can see how to include them. But we do not aim to just have research institutions in the network. That's not it. Yeah, thank you.
Yeah, and no, I'm not translating, but I'm saying what my translator explained to me. I think her question really builds on the question from Malawi about the challenge of explaining to other stakeholders what HTA really is and what it does. And at some point, I think sometime last year, I myself questioned why we call this HTA. Because the word technology, which is good, it's a standard word, but many decision makers actually think it has to do with digitalization. And yeah, I remember at the CDC, we got a request from a country to help do that, and we had a series of questions really. Should this not be done by the digital team? Why is the health economics team actually doing this? And I think this is one of the things that we need to contextualize, you know, HTA, especially when dealing with policymakers, because so HTA is one of the areas where we need to demystify. In fact, we have no option. We need to demystify the whole mystery around academic, you know, that this is an academic exercise. Because whereas we are trying to use standards that are, you know, very robust standards, methods, the questions we are addressing are policy questions. They are not academic questions. And I'm happy that some of the country presentations you would hear probably would help us understand a bit more, for instance, from Ghana and from other places. And so we need to find a way to better explain this to policymakers, the decision makers, so that they understand the basic problem. They don't have enough resources. That they understand. How do we use our methods to help them without making it look very complicated? I think that's where it is. And let me also state that, you know, in this whole endeavor, Africa CDC is playing a key role. You know, like she mentioned, the health-related quality of life work. You know, both CAMRI, AfroHTA, and Africa CDC have managed to get Eurocore Foundation to actually commit funding and expertise to support development of, you know, value sets for a couple of African countries. And I think that that is a great initiative that I know, I'm not speaking for them, but I know that, you know, they've been working with Camry a lot in this area. So all of these organizations are there. And as you can see, MSH is not academic. CHA is not academic. But this is an area where we need to bring all of those expertise. It's important for us to ensure that we link country level capacity to address the country needs, you know, rather than bringing external expertise to run the models and take the laptop away. Next time the minister wants, you need to bring that laptop back to Lusaka to address that. This is where we need a very concerted effort to ensure that we understand clearly what the policymakers need and we can, in plain language, explain to them how we are able to address that. So I believe I may have done justice, but justice is here, so.
Thank you, Justice, and thank you both, Marion and Angela. This is very informative. So now that we have a little bit of background and context and examples for HTA, I'd like to invite some of our country teams to share their experience. So I think we will begin with Malawi and Professor Joseph Mfutsu-Bengo, who is the Health Economics and Policy Unit Director at Kamuzu University of Health Sciences. Welcome, Professor Joseph.
Thank you very much. I'm a professor of bioethics and behavior sciences. Just to show you that HTA is not on health economics. It's a multidisciplinary, interdisciplinary process for prioritization in order to achieve equitable and efficient decision-making in So I'll start with where we're waiting. We'll start with a great paradox. When we're doing the assessment of HTA, we found that those who have got the higher the income, the lower, the higher the utilization of HTA, and the lower the income, the lower the utilization of HTA. I would like just to say that I'm presenting on behalf of the task force, and the chair of the task force is here, is Emily Chiwa. So I just wanted to say it is a work of the task force. Next slide, please. Well, yes, as I just already said that this is the greatest paradox, that those who have more, they are utilizing the HTA tool for achieving efficiency in their prioritization. And those who have got less, they're not using it. So it's also interesting to see that Donald Trump has started a department of what called efficiency. So those who have, next slide, please. So in Malawi, we did a study. The Health Economics Policy Unit, which I'm in charge, requested by government to look at feasibility and acceptability of HTA in Malawi. So we did benchmark, and then we found out that there was a demand for HTA for policymakers in Malawi. In Malawi, we had when we did the research, we found that there are 3 types of HTA processes, which we found globally. One was community-based, commit-based, and the other one was hybrid, and the other one was fully institutionalized HTA, like NICE, in UK. So in Malawi, you found that the process was disintegrated. It has got a potential that that limited use of evidence. Also, the potential that voting, both by donors and also voting from the politicians. It was suboptimal process. So these are the three papers we did. The first one was a qualitative study, and the second one was looking at value and evidence-based decision-making as a tool. We're trying to see what matrix, decision-making matrix we shall use in HTA. And then the third one was coming with a framework, decision-making framework. Next slide. So this is the, if you see there, in April 23, the senior management signaled that we should set a task force. And May, July 2023, HTA task force theories or terms of reference were developed. And August to October, HTA task force formed by MH Department of Planning. And November 2023, a session meeting which had two goals: to evaluate HTA across 4 pillars. That was governance, capacity, principles, and financing. And lastly, or to make recommendations for HTA institutionalization. So if you see, Malawi is a small country, it was for us as academicians, we were really surprised by how quickly MOH, Ministry of Health, understood it and started running with it. If you see the period, you see that we have really done a lot of process. We did everything correctly. We did the research. It was not just jumping. We did the research to what is needed in the country, the feasibility. We looked at acceptability. Then immediately when the government understood it, we did benchmarking. The Emir went around and with the team to see what is done in NICE and other countries, etc. Let's move on. Next. This is where we have chosen. I have said that when we did our analysis, we found that there are 3 types of HTA: commit-based, hybrid, and fully institutionalized agency, like NICE. We opted for hybrid. We moved away from commit-based, where a commit meets and they decide without a framework, without anything, to a structure, which is, this is the structure. Government, as the team and the task force has proposed that there will be HTA division in the Department of Planning. This will receive the request, the demand for HTA appraisal. This will go to, if there's no evidence, they will ask what we call health service strategic plan think tank. So this is where academic and the policymakers meet. It's a platform where it's what we call a marketplace for demanding and supply of evidence. So the demand and supply of evidence will be done by this committee, a think tank. Where will the evidence be demanded? From my poster labs? Poster labs are all research centers, academic organizations, but those poster labs will be accredited by the think tank. So Kemni, for example, in Kenya could be a poster lab, targeting one pillar in the health service strategic plan. So that's what happens. You get a demand for HTA, or they see the gap in knowledge, they refer it to the think tank. The think tank is an independent body. They will look at evidence. They will advise back the HTA division. The HTA division will supply that evidence to HTA appraisal committee. Appraisal committee then will make an independent decision, and then the decision will be recommended to senior management, MOHS senior management for decision. So you can see that. Why did we come with this option? We discovered that the full institutionalization alone cannot fight suboptimal decision making. So the fact that something is fully institutionalized without proper checks and balance, it can actually, you end up institutionalizing inefficiency, corruption. So we have seen government bodies which were part of government and now they're fully institutionalized. Now they've become more corrupt. So we say, no, we need to have a structure which is, has got checks and balance. So the think tank will resolve the issue of evidence-based decision. The HTA appraisal committee will resolve the issue of independence. And then MOH senior management will make the optimal decision. Move on. So you could see that when we say that HTA is multidisciplinary, interdisciplinary tool for prioritization. Where do the competences come? They come from different areas, disciplines. You need issues of clinical evaluation. You need ethical evaluation. It can be even illegal evaluation. You have got a cost effectiveness, patient rights, etc. Pharmacists looking at the safety. And this is where the members of the review panel, HTA review panel, will come from. So in order to resolve what other people say, they should not be only academic. And this is not only academic. We have tried to make sure that it is a thinking together between the researchers and the policymakers in order to make an optimal decision in order to achieve optimal health outcome. Let's move on. So we discovered that one of the people who said, I published a paper called Value and Evidence-Based Decision, critiquing what's called this mantra of this, evidence-based decision-making. Because evidence-based decision alone, without optimal value sets, even the demand and the supply of evidence itself, it needs values which value the evidence. If you have got value sets which value superstition, witchcraft, and even the best optimal decision evidence will not be adopted. So that's why it's very, very important to talk about the value and evidence-based, because you need value sets in order to make a decision. So I'm happy that there's a value sets funding to look at the value sets of HTA. These are some of when we did benchmark in different countries, we did our benchmark. We found that there are different value sets, but we said, what are the value sets which we need for Malawi? So we found that cost effectiveness would be important because we don't have much money. Equity, safety, acceptability, etc. Even sometimes you need issues of intellectual property. But these are just to show you that while we're talking about evidence-informed decision, we should start talking about the value and evidence-informed decision. Because without optimal value sets, even the best evidence will be ignored because of vices or lack of value. Let's move on. So myself and my team will develop an app called VetMap. It's an app which has got different levels. the first part of the stage of the decision making is where you look at the sector. So you say health, okay. Then you look what are the professional value, which in the health use, if you are looking at a drug, what are the values which you need to measure the quality of a drug? So you cannot talk about a drug without efficacy. You cannot talk about a drug about effectiveness or safety, acceptability. So these are, I'm not talking guessing, but you ask an expert to say, what are the value sets for your sector? You're talking about seed. What are the value sets for seed? For growth, what are the value sets you measure for a growth? After that, then you have to look at empirical value sets. So if you say effectiveness, then you have to check the empirical score of that effectiveness. So like a vaccine. So you say how much it is scoring on efficacy. This is what you say empirical. The third stage is you look at fidelity. Fidelity is where you expect that the score will be over almost 100%. But when you say acceptability, you need to know that drug, how much, what level of acceptability it is, or a vaccine among the people. Is it 50%, 60%, etc. And then again, we have got the last one is the societal. So the societal values like gender and all that are weighted lower than empirical professional values, because these are auxiliary. You don't need political will to make a drug. You can even make a drug without even politics. That's why they're not. But in order to implement it, you need politics. So that's why it is weighed lower, but it is needed. Let's move on. So, financing, HTA. We are to even think about how we are going to finance HTA. We found that it has to be funded by government through subvention, but also later it can finance itself, like ethics committee you charge. This appraisal, HTA appraisal, could be for a fee. People sit there, those people come and sit and look at the document and all that. Those are the need, you need to pay for their transport. That's why there's a fee like another committee. So we are thinking of introducing a fee. Continue. So the next steps, I think this is the last one, so the next step, develop SOPs, standard operation procedure for the HTA, drafting HTA mandate with support from Minister of Justice, as you have already said, that integrating it into a legal framework. Since making people aware, the lawmakers and people about HTA. Benchmarking of HTA, going to other countries to see, in order to optimize the framework which we have come to Malawi, in Malawi, we have developed in Malawi. We need to benchmark and see how can we optimize it. And come up with a report and make it into the law. Next. Thank you very much for listening. And I would like to also to thank those who are funding us. Thank you.
Thank you very much, Professor Joseph, and there will be an opportunity to ask questions during the discussion period. Next, I'd like to turn to Dr. Brian Osare, who I believe will be joining us online. Dr. Brian is the head of the HTA unit in the MOH in Ghana. Dr. Brian, can you hear us okay?
Hello? Hello? Can you hear me?
Yes, we can hear you.
Okay. Let me start the try and show my. Let's see whether you can see it.
Yep, we can see.
Okay, good. For network, I'll just show my face to start with. And then when I start presenting, I'll turn it off so that the connection can be smooth.
Sure, sounds great. And if you wouldn't mind putting
Okay.
your slides in present mode, that would be wonderful.
Yes, yes.
Thank you.
Okay. Yeah, so with your permission, I'll just turn off my video present. After that, I'll turn it on.
Sure.
All right. Yeah, so I'll be presenting on what has happened in Ghana so far with respect to HTA. And I'll highlight some of the few challenges that we faced in terms of trying to apply this very important and very useful piece of work. So we actually set up HTA to have a certain focus. And the focus in Ghana has been quite specific. It's been to prioritize our policy options, to define our benefits packages, to address issues on essential health services, selection of health technologies, pricing, and procurement. So this is quite clear. Then we also established a governance structure for HTA as part of how we would institutionalize it. So we have a secretariat that combines administrative and technical work. We also have technical working group, which is a clustered technical working group in that we have subcommittees for analysis, appraisal, capacity building, and all of that within the technical working group. And of course, we have a steering committee made up of the implementing entities that will be taking up recommendations from HTA. Now, all of this is within the state governance infrastructure. And we also identify the role of our partners, networks, and collaborations, as well as other stakeholders who are important, including even end users of the recommendations. For much more detail about some of the setups within Ghana, you can follow these papers. The other one on the reference case is in preprints and will be out soon. So just to give you a highlight of what is coming. But the good thing in Ghana is that we have identified key areas where HTA will be applied specifically. So Ministry of Health, pardon me for the acronyms, Ministry of Health Policy Planning, Monitoring, Evaluation Department. So yeah, they have interest in HTA to apply to policy. Medicine Selection Committee to apply to selection of health technologies. Health insurance, the NHIA, the Ministry of Health, other stakeholders to apply to benefits package. The same health insurance to apply to, and then especially Ministry of Health and Ghana Health Service, even private sector, faith-based sector to apply to the services, the essential services. And then the National Medicines Price Committee and procurement entities to apply to procurements. Having done that, we've gone ahead to define or set the agenda, the technical agenda for HTA. And we've identified 5 main technical areas with over 40 specific technical issues that could be addressed with HTA. And this has been the focus for our technical work so that agenda has been set and we know specifically the areas in terms of the specific areas that are priority for now. But having done that, we are also being responsive to the health system needs in terms of the need for evidence for decision making. So in terms of work that is currently ongoing, we just completed one piece of work in terms of the analytics. Of course, there are other policy processes that will continue, but in terms of the analytics, hydroxyurea for sickle cell, the report is ready. We've also just collaborated with the Norwegian Institute of Public Health to do optimizing cost drivers for iron deficiency anemia. That was at the tail end of last year. The ones that are hot on the agenda now is a budget impact analysis for the adoption of artesunate pioneridine as part of malaria prevention, malaria treatment policy in Ghana. Again, we also have another malaria-flavored work that is ongoing on deployment strategies for malaria vaccines in the country. These are just highlights of the ongoing pieces of work as we speak now. Of course, when we look back, we can always refer to, now that it's published, and for those who want further details, you can follow this paper for childhood cancer and the application of HTA in there. I mean, you can see from the charts that under several parameters of uncertainty, this was cost effective, and then also a reasonable budget impact, 5-year budget impact of less than $1 million. So that was easy for our insurance to pick and then include in the benefits package. Of course, in breaking down the drivers of that, we could tell that the patient count, the patient numbers was a significant driver for costs in terms of the budget impact. But then in implementing this intervention, we have also seen some teething challenges, which we have started working on resolving. And the challenge is very simple, though of course on the ground is complicated, is the idea that sometimes the implementation moves away from the parameters that you have used to do the analysis. That is actually supposed to inject the efficiencies as analyzed into the system. So there are certain practical things that you needed to ensure that those variables, the point of implementation to secure, because there's no point in analyzing and implementing another. So that has been a challenge at the implementation level of this. And I'm trying to speak in terms of end-to-end application, setup and application and uptake and use of HTA in our context in terms of a lower middle income country. So the outplay for the uncertainty that we analyze and transitioning that or translating that to actual practice is one key area which we are picking a few challenges from, but we are not leaving it. We are trying to intervene to ensure that we still get the best out of the work we do. Of course, some of us know this one already, another case where we have a pneumonia management in children and what are the best options for therapy. And this particular one saves our health insurance about 800,000 Ghana cedis a year. Then we have one. So the thing is that generally we have seen favorable uptake of our findings or our recommendations for HTA, but for a few cases. And we didn't want that few case to be like develop a culture in the policy environment for HTA to develop a culture of selective application of cases. We didn't want that. So if you follow this particular paper, the justice that is in the room is one of the key authors of this particular one, our HTA Technical Working Group Chair. So this work made specific recommendations, and we felt that decision makers went not exactly in line with the recommendations. So we decided to investigate those using implementation research approaches. And this was our findings, and that was a qualitative piece of work. So there are system issues, okay, structural and functional things within the system. And there are things that are related to the HTA process itself. if you want to promote uptake of HTA findings, then you needed to have a look at the structures and things that are not related to the HTA process and things that are related to the HTA process. But the things that are not related to the HTA process, you can have very little influence on them directly. But those that are related to the process, you can actually intervene. So the relevance of the content, you need to ensure that you are analyzing what is relevant. You need to ensure that you reduce the technical complexity and technical density of the content. And I'm happy that earlier, I think one speaker alluded to this, that they highlighted that how do we ensure that we don't make this an academic process, and we're able to communicate in a way that the policymaker understands. We are beginning to see that in our application of HTA in terms of reduced technical density. Then also timing and access to content. Evidence by decision makers needed, and they are needed on time. So if you are not able to respond on time, late evidence becomes difficult for uptake when decisions have actually moved on. The thing is that decisions will be made with or without evidence. It's not every time that policy decision making has the luxury of waiting for a 6 month turnover, 4 months turnover for an HTA analysis to be done. So how do we then ensure our rigor in terms of the scientific work that we do, and also make sure that we are responsive enough to be able to supply the needed evidence on time? This is what we try to respond to improve our uptake of HTA recommendations in Ghana. And we've actually designed a few tools to help us to be responsive and relevant, and also not too technically dense. So we came up with an approach, which is a customized approach to our setting. It's about a 6-step process that has key components to reduce technical density, to keep stakeholders continually engaged, to ensure that the relevance is kept, to ensure that even before recommendations come, the user of the evidence is in a position to actually understand what is coming and be able to identify the that is here. And we are using an implementation research approach to actually test this intervention and its effect. So far, the signals we are getting are good. But it is not just about stakeholders factor. Our approach to respond to that is to use prototype models that yield themselves to rapid adaptation so that we are able to respond to decisions that on time. So this is where we are. We are exploring statistical programming tools to build the prototype models. Our budget impact model is ready, and that's what we budget impact analysis. So I would end here, and the rest can be discussed. But this is just a short overview of current developments within the HTA space.
Thank you very much, Dr. Bryan, for that comprehensive and thoughtful presentation. I'd like to invite you to remain on the line, as well as invite Professor Joseph to come back and join at the front. I believe we also have one more colleague from Rwanda, Jean-Marie Sindambiwe, who has worked extensively on the HPP design process here in Rwanda. So please also come join for the discussion. So I believe for the majority of the remainder of the time, we're going to open up the floor. I think we're going to post some guiding questions, so we can sort of structure the discussion around that way. But if you all have any questions on anything you've heard throughout any of the presentations today, I invite you all to speak up. So we'll start maybe by taking some questions from the audience. And please introduce yourself as well, if you don't mind.
Yes, I'm Okaka from Kenya. I teach at a university in Kenya. Now, there's problem. So far, I don't seem to understand what HTA really is supposed to do, because there is a part where you talk about defining benefit packages. There is a part where you talk about looking for the efficiency in the supply chain systems. Then there are sections now you are interlinking it with the disease and how to control those diseases and so on. And the two, KEMRI, first one and the rest. In fact, at the moment, Kenya is having a problem with the current pooling system. The current government decided to expand the pooling so that we can include people in the informal sector. And suddenly we are experiencing a big problem. I hope you understand that recently even some providers are deciding to boycott the SHA, the expanded SHA, and the patients are facing problems. Is that part of a problem that this HTA can do? But can you pin it down for me? Because at the moment, I think it is all over the place, and I may not get what it is really supposed to do. Thank you.
Thank you so much.
Thank you. Camille Shoritira, MOH Nigeria. Thank you for the presentation and also those that presented earlier. I think mine is a comment which can assist us that at the highest level, advocacy needs to be done. Already WHO has published how to guide on the use of HTA. In August this year, the Afro WHO will be taking place in Lusaka. If we can have a side meeting to expose these ministers to this, many people, many organizations, MSH inclusive, in many countries are already making use of this toolkit. But for the MOH to adopt it, the ministers need to be aware. And that is why they're having the impression that it is for development partners, not for government. As a toolkit that can be applied to several processes. It's very useful. I think we should do something around that. High-level advocacy, we are aware, but making a decision, creating, institutionalizing it, require political support. Thank you.
Thank you so much. Maybe we'll take one more question if there is one, and then turn it over to our discussants, please.
Yeah, so I think for me, just following the process of institutionalizing HTA, at this point, the question that comes to my mind is, once you have these institutionalized, you're looking at, you're going to do some measurements, you're going to measure impact to be able to make the decisions. So in your countries, how does the data landscape look like? That's the first thing. The second thing, what methodologies are you looking forward to? And what level of expertise do you have? Yeah.
Thank you. Shall we take maybe one more? And then I'll turn it over to you both.
Thank you. My question maybe goes to my colleague from Malawi. I just a little bit understanding, is this kind of in the guideline level or it has been implemented? Because my previous work with PMRI and CMS, they never had mentioned anything about HTA or even understanding the existence. Having worked with them extensively, even developing their strategic plan, this never came up. So I don't know how far is it.
Thank you. One more? Okay, one more, and then we'll turn it over for real.
Chima Onoka from Nigeria. I like the hybrid model you talked about. Typically, people engage with the universities, directly. It's easy to have, interactions around that directly. Now, if the MOH is engaging universities, like you mentioned. How do you resource that interaction? Okay.
All right. Thank you all so much. And over to you both to speak to some of those points.
Some of the question, I think I will also, the chair of the task force is here, will answer one of the questions. Where are we here? So I will push to the government because the decision maker is here. So I cannot run around. My work is to generate evidence. The decision maker is there. So what is HTA? What comes in HTA? What comes out? This, I just wanted to, the gentleman who just spoke just now, the issue of efficacy, for example, and safety. They already, in other countries, there are drug and the agency, drug and what, FDAs. They can handle that information. What you need is just, that's why in the what called HTA panel, they are also a member from the drug agency. So but however, if there's no evidence on the drug, on the safety of that drug, for example, then you can refer this issue to the think tank. So the think tank will review and they say, no, we still don't have the evidence. Then they can commission the evidence to the policy lab. So what I'm just saying is not, HTA is not a pot where it has to cook everything. There's something which has to already have been cooked. It is just to refer, to get information. For me, the way I understand in my little capacity is a prioritization tool. Where do I put my resources? There are 3 technologies here. Which one is the best? Should I take this one or not this one? Should I take this equipment or that one? Should I take that equipment which has been donated? But before we take it, we need to do cost effectiveness analysis because we may take it, it's cheapest to take it, but the cost of maintaining it, it's even more. So they're giving you, but the spare parts are very expensive. So that's what we want that they should do in Malawi. You have got vaccines. I just give example in Malawi. We are doing, during Ebola, COVID. Vaccines were for free. Which one should we take? Should we take Pfizer? Should we take the other one? Why should we take Pfizer? We opted to take the other one. Why did we take that one? So another one is a tool to protect us from bullying. Because when there's a framework, you have got proper value sets, principles. No one can just come to say, follow this way. When there's a framework, there's a procedure. So that's why we are developing a standard operation procedure, the guidelines. So that's the other question. I hope that I've answered. It's a prioritization tool. It will not do everything, but what it cannot, it will refer to the think tank or to the policy lab where the evidence or other agencies who can do things, who have got the mandate to do it. On the question of what stage, we were lucky in Malawi. One of the biggest problems in Africa is also unnecessary bureaucracy. In Malawi, you found that the first meeting where this was, I think you will comment on that, it was presented to the senior management. There was a heated debate. And people were, what is this animal? What is HTA? But eventually, it was approved and endorsed. And immediately said that it should go ahead. So I think I will leave to the to answer that one. Can you answer it now before I proceed?
Is this about the way forward?
No, what is the status now in Malawi? Because he's saying that he was with certain gentlemen from the pharmacy and poison board, but he didn't know anything about the HTA. So they're saying, where are we? We are just talking, or it is true that there is HTA in Malawi, or it's only the paper in publication.
Yeah, so I think it all boils down to the fact that people are not well aware of what HTA is. Even myself, I'm still learning. I was unfortunate to be in a session whereby I had to convince the Minister of Justice to support us with the legal framework for HTA, but I struggled to explain what HTA is all about. And the questions that they were asking us was, what is the other bodies doing? So we've got the Medical Council, it's got some components of HTA. We've got the Poisons Board, the Pharmacy and Medicines Board. They also have some components. So the question was, if you want to say you want to do this under one roof, as in the Ministry of Health, what roles are these going to play? And for the roles that they're already playing, that are supposed to be under HTA, who will take it eventually? So those are the questions that people are asking, people are not aware. We are trying with them, we are trying. That's why I was saying, we also need more support on the ground. Maybe one person, we have a session so that people understand. But I recall during that meeting, we had come to a consensus to say that HTA is multidisciplinary. So assuming there is a drug that we need to assess, then the Poisons Board will come, because already they've got that function. Maybe already they've done some work on that product, so they'll come with the expertise. Medical Council will bring the expertise. The ministry will bring the expertise. The general public, whatever people, groups we need to bring on board, they'll come with the expertise, and together we make a decision. That's how we understood it. We are still learning. It's work in progress as Malawi. So yeah, so to answer your question, HTA in Malawi is not yet institutionalized. And there is these gaps that people need to understand. So definitely they are doing some parts of HTA, but they don't know. They are not aware. I wasn't aware that as senior management for Ministry of Health, we also have we have been playing a role in HTA. I had no idea. It's a thing that I'm also just learning. I don't know if I answered the question.
Yeah, thank you so much. I think maybe first I introduce myself, Jean-Marie Vianney from University of Rwanda, and I'm a health benefit package expert design. I'm designing or I'm supporting RSSP, Minister of Health, as well as University of Rwanda to design the benefit package. Of course, what they have said around the HTA, what comes in mind when someone say HTA, I think you already explained it. But again, maybe what I can add on, HTA can be a service, can be a technology, can be any interventions which can be done to improve someone's health outcome. So that one also can be in HTA. Maybe for me, I was not presenting, but the reason why we have not presented, we have a very nice presentation on Thursday, which will be talking about this HTA. Maybe for me, what I can say, just is sharing with you a little experience of Rwanda, if I may. Normally for us in HTA, because as I said, HTA can be a service, HTA can be intervention, it can be a technology. To as long as it improves the human well-being or an outcome. It means that for us on HTA, normally for us we focused on the interventions on cancer. Again, also we focused on the interventions on mobility or disability services. Initially, normally for the HTA, it comes from the ministerial instructions, which was established in 2021. It was also established due to an increased demands of the intervention because some intervention on cancer were not covered by the CBHI, and that HTA was designed due to those demands because like CBHI, it covers more than 91% of the total population. It means that the demand was high. So for us on the cancer services, of course, it has to be done, but also it is not a straightforward process because you have to select the intervention to be covered. You have to map those interventions, but also you have the criteria which can help you to make prioritization of those interventions which has been identified. So for mapping those interventions, you need to read more to see what is the gap. Of course, initially there has to be need assessment to see what is the gap. Then after identifying the gap, you map those interventions with the existing ones. So after the mapping those interventions, you also go through those criteria because we have like 10 criteria, including cost effectiveness, burden of disease, financial risk protection. We have an ability. We have different criteria to be based on so that maybe you can give the maybe those criteria, they are based to take the decision. It means that after the cancer interventions, normally we have the ad hoc committees. Those are the ministerial instructions because ministerial instructions was based on those criteria and setting the member who will be involving in those maybe for the approval, for appraising what has been done. Also, after doing those, we normally engage the experts in the field. Like for the cancer, we use it to engage the oncologist who could validate what was done. Because you may map the intervention and you can just, because intervention is mapped against the disease or condition, it means that the experts, they are the one to validate what you have mapped and what you have costed. It means that you have to map and you have to use all those criteria I have said, including cost effectiveness, burden of disease, financial risk protection, so that you can come up with the clear conclusion or the clear decision. Because when you map or when you use those criteria, it means that it gives you the picture depending on the budget allocation of that intervention, because you might have like a budget line of 5 billions. But those 5 billions, what are you going to cover? What am I going to use this budget? Of course, you have to make a mapping. You have to make a priority among the intervention you have selected. So what we did on the around the prioritization, of course, we had classification of those interventions where some interventions were classified into essential, others were classified into enhanced, and others were classified into basic. It means that all those interventions were classified in that, but it means that those interventions are classified, but linking them with the budget available. It means that for the cancer intervention, we are done with it. It was approved at the ministerial level. Now it is in other institutions like Minicofin. So that maybe if the budget is available, there can be implementation of those interventions. Thank you. Maybe in a few words, that's the experience on HTA in Rwanda, and now currently we are working on mobility services. Thank you so much.
Thank you so much to you both. I want to give Dr. Brian, if you're still online with us, a chance to respond as well.
Yes, if you can hear me, thank you very much for the opportunity.
Yes, we can.
Yes, so I think very interesting discussions I've been following. Just that I would plead your indulgence that maybe after this statement, I would have to move on so that I will go to another meeting. But the issue about the expertise that we need for HTA or the experiences that we need, I think In our context, the African context, in a lot of times, I think we would have to build the boat as we sail, in the sense that you are not going to get a very perfect setup from the beginning. And it will be good to just have the basics, and then you make progress and you can refine as you go. But what are the basics? I think a process for the analysis is important. A process to set the agenda, a process to set the questions that are important, a process to analyze, a process to take the results of analysis into decisions. Those are critical components, and the capacity to do all of this, so that if we are able to have these basic structures, it will be good to begin to make some progress and then refine as you go. We have realized that this process is a very dynamic process, and tailoring it to your requires of iterative feedback loops to do the refinement. That's the first one. I think the second one I wanted to comment on was the very first question, that what are the things that HTA is supposed to do? I think that is a very important fundamental question. But I have a very simple approach to answering that question. We've heard this question a lot of times. From its very name, HTA simply assesses health technologies. It simply assesses, so it's a very generic tool, assesses health technologies. Now, the question then becomes, what are these health technologies? Then you realize that the definition that we have for health technology is sometimes what really gives us the issue. Maybe we could have better called this assessment of health interventions, or you know, a broader, so the technologies here is defined broadly to cover policy options all the way to products, to a lot of the things that we do within the health system. It comes under the definition of what technologies are in this particular context. So it simply assesses those technologies defined very broadly in this context. And that is why it may seem that HTA is all over the place. It's like that because it's a generic tool. And you can actually, so the question is best answered by countries themselves. This is a generic analytical tool. And what do you do with the analysis? It's up to countries. In our instance, we have said that we would use it to define our benefits package, define our essential health service package, select medicines, we would even use to negotiate for prices. And all of that is possible within the scope of what scientifically or what technically HTA evidence is supposed to do. So I think a generic tool, and we can use it for so many things. So maybe I would pause here. If there are any specific Ghana questions, I would take. If not, then I would ask that I exit and catch up later. Thank you.
Thank you so much. Any Ghana questions very quickly? Sure, there's one.
Thank you very much. My name is Diane from Rwanda. My question will be to the presenter from Malawi and Ghana. I was reflecting on the institutionalization of HTA bodies. Like for Rwanda, as the one on the panel mentioned, it is an occasional thing which is not institutionalized. So I would like to ask you, who managed to institutionalize the HTA bodies, what changed? Would you recommend in like the number of the adoption of your recommendation has increased? Is the your targeted outcome while institutionalizing are being made is cost effective? Would you recommend? Can you give us some insight on the outcome of that process? Thank you.
Thank you. Dr. Bryan, I know you have to jump, so if you wouldn't mind kicking us off, and then feel free to drop when you need to.
Yes, I think this is a very important question as to really means as we try to institutionalize. In our case in Ghana, we had to use our policy environment TS3 to actually define what institutionalization means within our context. I know that recently Africa CDC and a few of the other partners are coming framework to guide institutionalization. And that is a very big plus to how we frame institutionalization of HTA within our context. But let me just mention 11 things that Ghana focused on when it comes to institutionalizing HTA within our context. And maybe some African countries may resonate with some of the things I'm going to mention. So number one, we felt that when there is a clear agenda set at the political level and a clear policy direction for HTA, if we can tick that box, it's a very important component of institutionalization. When there are governance structures for HTA, number two, that will be a good point to represent institutionalization. Number three, when there's a strategic direction for HTA, that will be a good thing. When there's a process for the conduct and uptake of HTA, that is a marker for institutionalization. When there are technical and institutional capacities for HTA, and the technical capacity is for the production, and the institutional capacity is for the uptake and implementation of HTA results, that's a marker for institutionalization. When there is production, you can't define all these structures and not produce the HTAs. So when there's production of HTAs, then it means you are institutionalizing. When there's a systematic process for the uptake of the findings, when there's monitoring of the implementation. In my presentation, I highlighted some of the challenges we've had with the implementation of some of them. So there should be a way to monitor the implementation. When there's a sustainable funding mechanism for HTA, and when there's a structured communication process for the results. And then lastly, when there is some form of legitimacy, whether it's legislation or policy, I mean, some kind of governance process. So has Ghana ticked all these boxes? We've ticked some of them, majority, but there's still a few ones that we've not ticked. So we don't have a legislation to support HTA at the moment. But to a large extent, we've said that we have been able to institutionalize HTA, but for a few of these other boxes that are left to be ticked. So I think countries need clear frameworks to define what institutionalization means in their context. But there are best practices, there are general guidance on this. And I'm looking forward for the Africa CDC framework that can be a generic Africa model that countries can adapt in their institutionalization process. Thank you.
So in Malawi, we can say we are around, if we score where we are now, we can say we are around 70%. Why? We did the evidence assessment, feasibility and acceptability. The MOH senior management has adapted it. Task force has put together a framework structure already done. And for me, what matters now is registration and the setting up of the division of HTA division, and also choosing the member of the HTA panel, review panel. For me, whatever you do, so long that that process is value and evidence-based, independent, and has got legal backing, and has got expertise, you can call it HTA. And again, what my friend has already said, is the ability to measure what you have agreed in an HTA, what called implementation fidelity. Is what you have agreed, the value sets, is what is being implemented? What has been chosen? Is it what has been, is it adopted? Because if you keep on prioritizing this one, they're not the level of adoption, they're adopting another thing, like what happened in Ghana in another instance. There must be, the framework has to be clear enough, robust enough, that for somebody to take number, if you say this is number one, this intervention will think that is number one. This one is number two, number three. To take number three to become number one, it has to be a proper justification that I take number 3 to become number 1. So I just wanted to give also another example of HTA. See, when you can have a very good efficacy data. I just give example in Malawi. Female condom proved to have high level of efficacy. In the part of safety and efficacy, scores almost 100%. And you found that it's about 10 years ago, people opted and funders started funding female condoms because they say, oh, want a gender empowerment. But only to discover that acceptability was almost 5%. So you spend a lot of money because you were running with only 2 variables, efficacy and safety. But if there is a low acceptability, it's also an issue of safety. So that's why if you have got HTA, I wanted that to explain as an example. Then you check, you agree, what are the value sets you need to have an optimal adoption of a drug or a medical device, a condom. Then you can say, okay, efficacy, safety, accept. So if it scores on efficacy and safety, but it doesn't score on acceptability, then you send it back to say we need evidence of unacceptability. But now, without this framework, with gender empowerment, people go to the minister, they'll go this, they'll be bullying, and they will adapt their gender. Oh, we need to empower women. Women, there's a pressure, people will adapt the condom, and they will implement the condom. And do you know what happened that time? Female condom were missing because all the money went to female condom. So the men were not wearing the condom, the female were not using the condom. So both lost. So I just wanted to give example how the this HTA can work. Concerning Malawi expertise, we are lucky also in Malawi, a place that Health Economics and Policy Unit, which I'm directing, was created to respond to government evidence needs. So we are there only existing for the government. So the expertise are on the cost effectiveness, on the health economics. Probably we can boast that we are housing, we can boast in Africa that we are housing about 5 or 7 health economics in one roof. 7, 8 in one roof. I'm not joking. In one roof, in a poor country like Malawi, we're having those in one roof, and then other people. But we have got a lot of capacity in this, and then we have got, we are creating the think tank mechanism where we can actually access evidence from different research centers. We want to do away with this framework. We want to do away with briefcase evidence generators. Briefcase evidence generators who have no capacity, but they go around providing evidence to the business and all that, recycling the same thing. So we are saying, who have a think tank, a marketplace where evidence will be supplied and demanded. If there is no evidence through synthesis, then we accredit post labs. So post lab will be an investor who has proven to have capacity in that area. So clinical trial, so they'll be accredited. So then the think tank will commission to this. But not every person who goes around the street and say, I'm providing. So if you see our structure, we have put check and balances. We have made sure that the policymakers are not making decisions based not on assumptions, but on evidence. And also that there are clear value sets selected in the process. I don't know whether I've answered on that. And on the measuring impact, this is the most important. We call this we are, if you look at our framework, has got what the Venmark framework looks at normative and actual values. So normative value is what you have agreed on the decision on adoption. And the actual value is the value set which is used at the level of implementation. So we have created a framework which we will be measuring alignment or misalignment on normative, what has been agreed, on adoption, on the decision, what called HTA decision, and on the adoption. Is it aligned? Why then when it is misaligned, then we say what are the motivations for misalignment? What is the cause of misalignment? Is it system based? Is it corruption? Is it ethical? Is it scientific? So there is our framework also is measuring that. So the normative and the actual value. Thank you.
Thank you so much. Do you want to make one last comment? I know that we're over time, but please feel free.
Yes, sure. Maybe if I may, on the last point you have highlighted, of course, you also have to look at the feasibility when you are implementing the HTA, the accessibility, but especially on the feasibility, because you might set the criteria or the priority which you cannot even implement. So you can look at the feasibility on the provider part, even at the client part, because when you are going to implement any intervention, you have to look at is this intervention going to be implemented due to the budget you may have. So normally you have to look at all those aspects, especially on the feasibility, acceptability, even the sustainability due to the budget you have. Thank you.
Thank you. And thank you both so much for all of these amazing insights and based on your experiences in Malawi and Rwanda. Thank you so much. Yes. I recognize that we're a little over time and that we are the only thing standing between you all and some more coffee and snacks. So I'm going to turn it over to Marion to close us out, but also just wanted to give a big shout out to the IT team. I know it takes a lot of coordination, so thank you all so much for your support.
Thanks, Ishani, and thank you to the country teams who made time to come and share their experiences with us. Very, very interesting conversation, and particularly what Professor Joseph mentioned at the end about the condoms. Health financing, like HTA, like most of health financing, is highly political. So we also have to explore contexts of political economy and political and social norms in different countries before we can institutionalize certain things in different countries, in our countries. So just key takeaways, I just wanted us to leave this room with, the high notes of what we discussed so we don't forget. What some of the key things that came up, we didn't have time to go through the discussion questions, but I believe what kept coming up in the different country experiences is the need for awareness and capacity building as important precursors for HTA institutionalization. The need for countries to define their scope. As you heard, different countries are using HTA for different things. So there's a need for countries to define their scope to be able to start. You don't need a full-blown agency to start, but you need to start somewhere. And then the need for partnerships. Kemri is here. She discussed about the AfroHTA network, and they're open, taking more members. Those partnerships can be leveraged. Malawi has a lot of capacity. That capacity can be used to train other HTA bodies in other countries. Or you can go around different countries in Africa, teaching others how best to start, or showing other policymakers how you are able to communicate to your own policymakers to be able to institutionalize HTA. And of course, the last one that I found interesting, the doing away with briefcase evidence generators. Yeah, HTA needs to be fully institutionalized. That way we don't hire consultants to tell us what's cost effective and what's not in our contexts. If it's fully instituted in our policy and legal frameworks, then that way we can be able to make decisions based on how much money we have to spend on health and what is feasible and sustainable within our countries. That said, we'll stay around in case anyone has extra questions or wants to chat a bit more, but I won't hold you any longer. Thank you. Thanks again for making time to come and,